Welcome, everyone. We're just about to get started. We'll just let people log in just for a minute or so, and then we'll get started. All right, I think we can get started as people are logging in. Welcome, everybody. We are so glad that you're here with us today. My name is Preeti George, and I'm the project director for SAMHSA's National Training and Technical Assistance Center for Early Serious Mental Illness, also known as the ESMI TTA Center. So we're so pleased to welcome you to the webinar on supporting young adults experiencing early serious mental illness in the shift from child to adult mental health services. Next slide. So here we just have a note on the disclaimer that the views, opinions, and content that are expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Next slide. So we have a few housekeeping notes before we get started. Just wanted you to know that this presentation is being recorded. We will be making the presentation slides available afterwards via email. And during the presentation, you are welcome to submit questions through the chat or through the Q&A function. And you may notice that there are a few people on the webinar participant list who have the ESMI TTA Center name displayed next to their names. You can feel free to reach out to any of them during the presentation if you have questions or need assistance throughout the webinar. Next slide. Okay, so here is the agenda for our webinar today for the overview. In a moment, I will introduce you to our speakers, and they're going to be sharing some very helpful information about ways that young adults who are experiencing early serious mental illness may be supported as they shift from child to adult mental health services. And we're going to have two grantees present approaches that they've used to enhance care for young adults who are experiencing early serious mental illness. And at the end of the presentation, we will have a Q&A session to go over some of the questions that you've included in the chat or the Q&A function. And we'll have some closing remarks to finish. So next slide, here we have the term ESMI. We're going to be using that throughout the presentation. And just for reference, the term ESMI refers to SAMHSA's working definition of early serious mental illness. You can see the full working definition here. But essentially, the term ESMI, it refers to a diagnosable mental, behavioral, or emotional disorder of sufficient duration to meet diagnostic criteria specified within the DSM-5. And ESMI is intended to refer to the initial period of onset of a condition. Next slide. So these are the learning objectives that we have for today. Throughout the presentation at the end, we hope that you will be able to learn more about the structural and procedural changes that happen in the move from child to adult service systems. We'll talk through some of the promising strategies to help reduce service gaps, including using early planning, using assessment, cross-system coordination, and personalization of step-down programs. And then we will learn from grantees who are implementing these approaches in their work on how they have found that work can be improved to improve the continuity of care, to help minimize disengagement and enhance service availability for young adults who are experiencing ESMI. So those are the things that we're going to be doing today, and we have a panel of wonderful experts to speak to you about these topics. We're so pleased to introduce our speakers for today's webinar. So we have Catherine Sabella, is an assistant professor and director of the Transitions to Adulthood Center for Research at the Implementation Science and Practice Advances Research Center within the Department of Psychiatry and Behavioral Science at UMass Chan Medical School. Dr. Sabella's research creates new knowledge about the needs and experiences of young adults with serious mental health conditions to inform the development, the testing, and implementation of services for this population. She is the co-PI of the Community Inclusion and Reflective Collaboration Center with Dr. Thomas, whom I'll introduce in a moment. And that center seeks to improve community participation outcomes among young adults with serious mental health conditions. We also have as a speaker, Dr. Elizabeth Thomas. Dr. Thomas is an assistant professor in the Department of Social and Behavioral Sciences at Temple University's College of Public Health. Dr. Thomas serves as an investigator within the Temple University Collaborative on Community Inclusion, and she's the co-director of the Community Inclusion and Reflective Collaboration Center. Her research focuses on promoting community participation among young adults with serious mental health conditions, including those who are experiencing first episode psychosis, college students, and other populations that require enhanced psychosocial support. We're also very pleased to welcome Hilary Burdish as a speaker as well. Dr. Hilary Burdish earned her PhD in clinical psychology from Farley Dickinson University. She holds a board certification in clinical neuropsychology from the American Academy of Neuropsychology. She is the project director of a new step-down program from On Track New York that is funded by SAMHSA. Dr. Burdish also supervises neuropsychological assessments within the early treatment program for psychosis at Sutter Hillside Hospital, and she carries a small caseload of psychotherapy patients. Additionally, she consults on neuroimaging grants that are funded by the National Institute of Mental Health, and that work is investigating the underpinnings of early psychosis. And last but certainly not least, we have Brittany Grimes. She's a project manager with the Oklahoma Department of Mental Health and Substance Abuse Services, where she has worked since 2022. Before working at the department, Brittany worked in direct care as a behavioral health case manager and a behavioral health coach for close to 7 years, and she served families, children, youth, and young adults, utilizing the wraparound and transition to independence models. Brittany's primary focus is working with youth and young adults who experience mental health struggles, particularly those experiencing clinical high risk for psychosis. So with all of that, we're so pleased. Please welcome Dr. Thomas, who's going to get us started.
Well, thank you so much, Preeti, for that nice introduction. It's a pleasure to be here with you all today. And Preeti mentioned the definition of ESMI earlier. I just want to add a bit more context to this discussion and say that when we're talking about young people who are completing their tenure in ESMI services and are being discharged, we're essentially talking about two simultaneous shifts. The shift from ESMI to less intensive services, and the shift from the child to adult mental health service system. And this is because youth are often receiving ESMI services at a time when they're about to age out or are aging out of the child mental health system. As many of us know, this shift is known to carry a heightened risk of service disengagement. And you'll see this Paddock study from 2008 cited at the bottom of the slide. It is dated, but it's still relevant today. And it showed that mental health service use dropped by about 45% as youth aged from 16 to 17 to 18 to 19 years. And there was a slight increase after the age of 20, but service use never really returned to the levels seen during mid-adolescence. We can go to the next slide. So before offering some solutions for improving service engagement and other outcomes, we're going to spend a bit of time talking about some of the structural and procedural changes during this shift from child to adult mental health services and note some of the specific challenges that are associated with these changes. Next slide, please. So first is the change in care philosophies. For the purpose of illustration, we recognize that we are talking in generalities here, and we recognize that there are meaningful differences across programs and service systems. But we do see certain trends emerging when comparing ESMI and youth serving programs with adult mental health services. So ESMI programs typically emphasize a more developmental, family-centered, and holistic approach to care. These programs are really designed with the understanding that young people are navigating critical periods of identity formation, education and career, and social development. And as a result, interventions often involve collaboration with family and caregivers, attention to work and school functioning, and support for broader life skills and community participation. For example, a young person might receive support not only for symptom management, but also for navigating a return to college or repairing strained family relationships. Adult mental health services, by contrast, are generally structured around diagnosis-driven, more individually focused models that are often more reactive and crisis-oriented. These settings tend to prioritize symptom stabilization and medication management, sometimes with less emphasis on meeting the developmental needs and relational supports of young adults. For instance, rather than involving family in treatment planning, services may assume that young adults are independently responsible for managing their care, regardless of whether they have the developmental capacity or the support system to do so effectively. We can go to the next slide. So another important change is this shift. During the shift is a reduction in service coordination. So ESMI programs are typically designed to provide, again, comprehensive wraparound support to address the multiple interconnected needs of young adults. This often can involve more intensive case management and structured coordination across various domains, such as mental health, housing, employment, education, even physical health. And the goal is really to reduce barriers to engagement by meeting young people where they are and helping them access a full range of supports needed. For instance, a case manager or a supported employment and education specialist within an ESMI program might accompany a young adult to a job interview, help them apply for housing assistance, or coordinate directly with school staff to support academic accommodations. In adult mental health services, by contrast, care tends to be more fragmented. And while some programs do provide case management, it's often more narrowly focused on meeting basic needs or mental health needs rather than addressing the developmental needs of young adults. And youth moving into these systems may find themselves suddenly responsible for navigating rather complex and unfamiliar bureaucracies, doing things like seeking out employment resources, finding transportation to appointments, with little to no assistance, which obviously can be overwhelming, especially for young people who are still developing executive functioning skills, still developing independence, or who lack strong natural supports. We can go to the next slide. Finally, a third change that we wanted to highlight is this potential change in eligibility criteria and service availability when young people are moving out of ESMI programs. As with other areas, the specifics of referral pathways and handoff processes can vary widely. But again, there are some general patterns that emerge when we have observed different systems. Many young adults encounter stricter eligibility criteria when attempting to enter adult mental health services. So, for example, while ESMI programs are often taking a more inclusive approach and serve a broader range of diagnoses, including things like unspecified mood disorders, anxiety disorders, even behavioral conditions, adult mental health services may restrict access to individuals with diagnoses of an SMI, schizophrenia spectrum disorder, major depression, bipolar disorder, which can result in a sudden loss of access to care, even when young people may continue to experience significant symptoms or functional challenges. And finally, service availability can also differ substantially between systems. ESMI and child mental health programs often involve services such as, again, wraparound care or family psychoeducation, which are supports that may not have a direct equivalent in the adult system. And on the other hand, some services within adult mental health may not have been part of a young adult's earlier care experience and may not fully align with their needs or preferences. So I'm going to turn it over now to my colleague, Dr. Catherine Sabella, to continue the conversation about this.
Thank you so much, Liz. So thank you so much for outlining the common challenges that we see. And before we get into more of a strengths-based, solutions-based approach, just wanted to summarize what some of the common consequences are of these changes. With more than 500 people on here, I anticipate lots of nodding in the next minute or so. So first, for systems who are responsible ultimately for serving the needs of young people with ESMI, we see as a result of these challenges, these silos in governance and funding streams. And what those silos do is a multitude of additional challenges or secondary challenges regarding who is responsible for this young person, who is ultimately responsible for their care, and also a lot of kind of confusion and or what I consider these cliffs through which a young person and or their family member could fall because they are trying to navigate these different siloed systems. We also know that there's limited data sharing and inconsistent coordination between these systems, which again can lead to additional secondary challenges. And similarly, a lack of standardized protocols or pathways from the child serving system or ESMI system to the adult system. Perhaps what I think is most important and should be a priority for us are the challenges that young adults and their families face when navigating these system divides and these challenges in that shift of care. Importantly, we see a lot of interruptions in therapeutic relationships. Workforce sustainability is a problem plaguing our mental health system, but add in the shift from child to adult services, and more young people are having to start over or have, are experiencing a lot of discontinuity in care. This creates a lot of frustration. And we've heard from young adults in our own research. I'm like so sick of telling my same story. And every time I see a new provider, I've got to start at zero. Like, why can't they share this information? And that discontinuity in services also can lead to different diagnoses, medication changes, and other experiences that can affect a person's well-being and ability to function. The family involvement changes as well during these systems, during the shift of systems. And for some young adults, that might be beneficial. For others, it might not be. And either way, almost always we see kind of increased tensions or challenges between a young person and their family of origin in this shift from child to adult systems. And all of this is really important. And like I said, should be prioritized because of the risk of disengagement. Liz quoted some data earlier. I'm preparing another presentation, and sure enough, the 2023 National Survey on Drug Use and Health shows once again that among adults with serious mental illness, young adults, the ages 18 to 25, report the highest rate of unmet need. Almost 60% of young adults ages 18 to 25 with serious mental illness say they have an unmet need. And I can't help but think some of these challenges are related to that. Next slide, please. Again, let's try to get more strengths-based, solution focused. So now we're going to turn our attention to strategies on the next slide. Again, high-level suggestions, and then our friends later are going to give you some more real-world examples. But some tenets of support for young adults that are really important. Early planning, involving young adults, families, ESMI service providers, and adult mental health providers in planning meetings well before service changes occur. If somebody's coming to you in crisis, you don't want to add additional stress to them. But this idea that if somebody is in child services for quite some time, the transition to the adult services should not come as a surprise. It should be something that they see on the horizon and that the team is working towards over time. Providing education to young adults and families about the importance of continued care for mental health recovery and helping them transition to that care is really the essence of what we're talking about here. But using a case formulation approach, again, an individualized approach that can kind of capitalize on the goals of the young person and or their family member and prioritizing those goals within the planning process to kind of engage and keep interest level and appeal up. Next slide, please. Cross-system coordination is so important. And like I said, we still see so many cliffs in the shift from child to adult services. In the last 30 years or so, we see more and more service systems understanding that 18 is not the only magic number, but all that has done in some cases is just made a smattering of these age kind of cutoffs across services. And so for somebody who is involved in multiple systems and then navigating the child to adult system, there's the potential for even more cliffs that they could kind of fall off of. So cross-system coordinators, peer specialists, especially young adult peer specialists, can help bridge the gap between child and adult services. And in-person linkages, we may have heard that term warm handoff before. And a fellow colleague at one point when we were visiting a service agency in New Mexico was like, what is a warm handoff? There is no definition of it, but it sure as heck isn't just handing a piece of paper to a young person and saying, call this person, because as of next week, I can't help you. You need to be maybe walking with them down the hall to meet that service provider or meeting them at the service provider, the adult service provider, anything you can do to really have a real world kind of connection to them. And again, ensuring some timely follow-up with adult mental health providers. Young adults will flake out. They will miss appointments, but don't discount them. Don't count them out. Don't make them start the system over again. Find ways to kind of make policies that will help support them. Next slide, please. Finally, just a note on evidence-based and promising practices. I saw this firsthand when I was doing some of the cross-site evaluative work with the Healthy Transitions grantees back in 2018. And our speakers this afternoon will kind of really drive this home. But the reality is there are no, gold standard evidence-based practices for young adults with mental health conditions. There are plenty of evidence-based practices for adults. Many of them do work for young adults, but developmentally, culturally, socially, young adults need a different approach in many cases. So what systems are doing and are doing quite successfully is blending some of these promising programs. You have TIP, the Transition to Independence process, that is often used. They've got some great worksheets, ways to support young people and engage with them towards multiple life domains and goals in multiple life domains. Achieve My Plan, again, is kind of an add-on to almost any intervention that you're doing to really empower young adults to have a voice in their planning services. Motivational interviewing, shared decision-making, trauma-informed care, those cross the age boundaries, but again, are really important in working with youth and engaging with them in meaningful ways. And again, principles of wraparound or coordinated specialty care. Young adults have many things going on in their life, and it is not just about their mental illness. And in some cases, they don't have the same sense of this as a medical diagnosis that older adults might have. So really finding a way to coordinate services beyond just mental illness treatment is going to be very important. I'm going to turn it back to Liz, and we'll go from there.
Thanks, Catherine. One other promising strategy for improving outcomes is the use of data-driven approaches that incorporate formal assessments and/or structured decision-making and care planning tools. One of these is the Transition Readiness and Appropriateness Measure, or the TRAM. This is a structured assessment that's in the public domain and available in several different languages. And it evaluates key areas, including things like symptom severity, functioning in areas like self-care, household chores, relationships, work and school performance. It also looks at risk factors and system or other life changes that can signal readiness or not to move into adult mental health services. And research has shown that using tools like the TRAM can help tailor discharge planning to the individual and support better outcomes. So this Singh et al. Paper from 2023 is one of those studies. Another idea here is to use semi-structured tools and checklists to ensure that essential areas are being addressed prior to discharge. These can include advanced crisis planning or psychiatric advance directives, which outline actions that should be taken if a mental health crisis occurs according to the young person's preferences. Some tools also prompt providers and young people to plan for accessing a range of services, housing support, medication management, vocational services, community-based peer supports. And tools like this really can help ensure that no critical areas are overlooked in the process of making these shifts in services. Risk assessment is obviously another critical component here. This really may go without being said, but discharge should be avoided to the degree possible during periods of crisis or heightened risk. Discharging a young person during a crisis or immediately following a crisis, such as right after a hospitalization or certainly a suicide attempt or loss of housing, could significantly increase the likelihood of disengagement and poor outcomes. So careful assessment of risk should be an essential gatekeeper in the discharge process. And finally, it's essential to go beyond clinical needs and think about broader areas that are central to young adults' success and well-being. Things like community participation, housing stability, education, employment, independent living skills. For instance, a young person who is psychiatrically stable but facing eviction or social isolation may still require substantial support during this shift. And a truly person-centered approach considers these domains to ensure continuity of care and effective growth into adult life. Go to the next slide. Many programs are also now implementing personalized step-down approaches that taper services based on a young person's evolving needs and provide structured support for identifying and securing post-discharge resources. Building on the earlier point that I made about assessing community participation, it's really critical during this step-down period to focus on functional skills that support both daily living and sustained engagement in care. Things like time management and problem-solving skills that are needed across contexts. One innovative example that I'll highlight quickly is Philadelphia Peace Program's Step Up initiative, which integrated occupational therapy as a core component of step-down care. This program assessed both strengths and needs in areas like daily living and social and leisure participation, and used individualized strategies, including environmental modifications and role plays, to help clients reach their goals. They also received assistance in securing ongoing mental health care and developing crisis and advanced directive plans. In a recent evaluation, this Thomas et al. 2024 paper showed promising outcomes, including both clinician-rated daily functioning and client-rated satisfaction with occupational performance. So I will now turn things over to our next speaker, Hillary Burdish, who's going to tell us about another example of a step-down program associated with On Track New York.
Thank you, Liz. So as Preeti mentioned earlier, my name is Hillary Burdish, and I am the project director for Living Independently for Tomorrow, or we call it LIFT, which is a step-down program from On Track New York, which is our coordinated specialty care program across New York State. Next slide. So before I get into we actually do, for Lyft, I thought I would start with an overview of On Track New York. I'm aware that a lot of people on this call are probably familiar with On Track, but for those who are not, or just as kind of a review, I figured I would start here. On Track New York is a coordinated specialty care network for early psychosis. There are about 31 sites all across New York State. Many of them are located in the New York City area. I am at Zucker Hillside Hospital, which is right outside the city, but they are really all over the state and upstate, some of them are rural areas, and out on Long Island as well. In order for an individual to qualify for On Track New York, they must have a diagnosis of a primary psychosis. And then depending on the site, they have to have a symptom duration of 1 or 2 years. At my site, it's 1 year. At a lot of the other sites, it's more like 2 years. And basically what On Track New York offers is this beautiful package of care that's custom made to our population. We do offer in On Track clinical services. I was a primary clinician for On Track before I moved into my role with Lyft. And we offer clinical services. There is medication management, although participants are not required to take medication. They are required to do check-ins with their providers who oversee medication. There's also the option for them to do individual psychotherapy and group psychotherapy. But again, all of the clinical decisions are made in conjunction with the participant. So the providers can make recommendations, but the participant also has a say in terms of what they want their care to look like. And then in addition to the clinical services, we have additional specialty supports, including peer supports and supported education and employment supports. So it really fills a lot of the needs for these participants at this particular time in their recovery, which is often right after, an initial diagnosis or a hospitalization. And really the only hard part about On Track is that services are only designed to last for roughly about 2 years. And in my experience as a primary clinician from On Track, a lot of times it's just at like maybe the 1 year mark that participants are just getting started using the services. Often they need the first year to kind of, process this new diagnosis, think about what they want to do with medications. They're not ready to connect yet, or they're not ready to engage yet. So once they, work through all of that and they start to really engage with On Track, they're kind of moving towards graduation at that point. So the time frame can often feel difficult. Next slide. And I think that Catherine mentioned this idea of a cliff, like a services cliff, earlier, and that's what a lot of the On Track participants experience. Once they are starting to move towards graduation, they feel like they've had this great package of services through On Track, and then they're about to graduate and move to standard care, more adult services, and they feel like they're falling off a cliff. But this is where the LIFT program comes in, and we aim to move them or transfer them into standard care in a more gradual way, and ultimately to transfer them into the community in a much more gradual way, like the second figure on the slide. Next slide. So in terms of our LIFT program, LIFT does not offer clinical services, but we work instead in conjunction with clinical teams, and we accept referrals for LIFT from on-track programs all throughout the region. And before I get into the specific roles for LIFT, I just have to say most of my team, I think, is on this call today. So, I mean, they are fantastic, this team. I couldn't be doing this without them. And I'll start with the care coordinator role. So similar to On Track, Lyft has a care coordinator who has a few different roles within the program. The first is that she helps to coordinate the new referrals coming in. And she also really is the front face of Lyft as we go into the critical time intervention approach, which I'll get into on the next slide when we get there. But that's actually how we transfer people from On Track New York into the Lyft program. We then have a youth and young adult coordinator role, and this role parallels the peer specialist role that there is in On Track. So it's often an easy shift from On Track to Lyft in that way, because a lot of participants are already familiar with working with a peer. We again have a support education and employment specialist role, very similar to On Track, but often at this stage of recovery, participants have experience working with the Cs and are further along in terms of work and career goals. And then our new role that there isn't in On Track, but is very important with regard to Lyft, is our activity specialist role. And our activity specialist really covers any aspect of independence that isn't that isn't covered by the other roles. It's more than case management. She helps people learn how to cook. She helps people with like learn how to do laundry, open a bank account, transportation, getting a driver's permit. So all of those needs that the participants have at this stage of recovery, we have somebody who can support participants with that. And again, just holistically, it's designed as a program to ease people out into standard care and eventually the community without them having that feeling of falling off a cliff. Next slide. So I want to spend a little bit of time on the critical time intervention approach because this is unique, I think, to our program. And it's something that we're using, which is really working to help people transfer from coordinated specialty care to LIFT services. And by definition, CTI or critical time intervention is a time-limited evidence-based practice that mobilizes support for individuals in need during periods of change. And CTI, it originally started with a population of people who had SMI and were unhoused. And it was observed that a lot of people, once they were moved from the streets into supported living, often people would default back to living on the streets again. But with a more gradual shift, in housing situation, people were more likely to stay in supported housing. So CTI started there. A lot of great work was done at the Hunter School of Social Work, which is right here in New York City. And more recently, I've seen CTI being implemented in all kinds of, changes during recovery. So at my hospital, from what I understand, they're implementing CTI when people move from inpatient to outpatient. And I've seen that New York State is funding CTI teams. First, it was just in the New York City area, but now it's actually throughout the state. So I think people are really seeing the benefits of this. What CTI is it's the empirically based definition is a 9-month process of transferring people from point A to point B in their recovery. And it begins with a program shift. So for example, in our program, typically the on-track team initiates the discussion with participants regarding eventual discharge. And they say that, they have this plan and that we have this LIFT program and you can have these additional supports once you graduate. And if the participant expresses interest, then the LIFT team starts to mobilize. And typically it's our coordinator that comes to an initial meeting in conjunction with the on-track team member and introduces the LIFT program more directly. And during that call, if the participant, so expresses interest, the coordinator kind of gets a sense of what services the participant would most likely be interested in connecting with. And often that's based on what they're using through on-track. And then once, it's kind of agreed that we're going to move in this direction, we enter the tryout phase. And in the tryout phase, which can last a very long time, this is the part that can last up to 9 months, the LIFT providers often work with the parallel on-track providers and join their sessions and really get to know the participant, and the participant gets to know them. And it really has this phase multiple benefits. So the participants really see the LIFT providers in action. They get to learn about them. Likewise, the LIFT providers get to work directly with the participants, and there might be new needs or a need for new resources that they may be less familiar with that they have the time to look into before the participant actually transfers over to LIFT. And in addition, the LIFT providers get to observe the on-track providers working, hands-on with the participants. So they get to see what works and what doesn't work without having to reinvent the wheel. So this process can take an extended period of time until finally we transfer people over into the LIFT program with the standard care clinical services alongside that. And really, this process works so well that a lot of our participants have said that they don't even feel like they're moving into a new program. A lot of times the movement from one program to another can be a point where participants disengage from treatment, but with CTI in place, of all the people we've started to enroll in our program, we haven't lost a single person at this point, yet. And I credit that to use of the CTI process. I should say that we are not using for the LIFT program the traditional evidence-based CTI model. We're doing a more CTI-informed model, really tailored to the participants' needs. So although we have 9 months to do this transfer process, we've averaged so far, and this was as of April, about 2.9 months from the initial introduction of the LIFT program to enrollment. And that ranged from about a week until about 8 months. But it's been incredible in terms of keeping people engaged post on-track graduation. And then next slide. I do have a case example. I don't think I have time for it today, so maybe this is better for a different time. We want to move to the next speaker.
Brittany, I think you might be muted. We still can't hear you. Do you think? Oh, great. Well, we're just going to manage some of our audio connection here. Brittany, can you? Can't hear you right now. We can try to figure out your audio. So while we're doing Brittany's audio, I don't know if Hillary, do you think you could just talk a little bit about your case example just for a moment while we get Brittany's audio back?
Yes, absolutely. So I picked this particular individual because it was somebody that I started working with back when she was enrolled in On Track, and I saw her all the way through to the end to graduation from LIFT. So I have a full, picture of what her care looked like all during that time. So this is someone who is 23 years old. She started with me in On Track back in November of 2021. She had just come out of a 2.5 week hospitalization with a diagnosis of a primary psychosis. And we did have some initial visits with me as her therapist. A lot of it was focused on symptom management, and she also was in a relationship that was, I wouldn't call it abusive, but it was really not the healthiest of relationships. So we talked about a lot of strategies for managing that. And then, like a lot of the other On Track participants I worked with, after those initial few sessions, pretty much for a lot of 2022, she disengaged from treatment. And I'd see her occasionally. She would come, especially for the assessments that we do as part of that program. She often didn't want to turn the screen on, or when she did, she just, didn't look, she looked very symptomatic. She was struggling with whether she should take medications. She was not doing well in school. And, things lasted like that for about a year. But later on, she kind of said she always knew I was in the background and that she could choose, when she was ready to start to do psychotherapy again, which in 2023 she did. At that point, she broke up with this boyfriend. She made the decision that medication worked for her. Her symptoms were much better managed. She became much more engaged in life, in relationships, in work and school. She was going to the gym. And then, of course, it was around that time that she became slated for On Track New York graduation because her 2 year mark was coming up, and we did keep her a little bit longer. So just to summarize, because I see that Brittany is almost ready, but 2024, in the spring of 2024, we introduced her to the LIFT Care Coordinator because she expressed interest in, trying out this program. And gradually over the course of 2024, the coordinator introduced her to the other LIFT roles. She developed a especially strong relationship with our Cs, our Sport Education and Employment Specialist. And then by the end of 2024, she really had a good connection with the LIFT team, and we enrolled her. It was actually Christmas Eve day of 2024. And she was one of the ones who said that she didn't feel like she was moving into another program because she knew us all so well. And that time was a very important time of her life. She had been in this new relationship. She married her fiance. She was about to graduate college. Her C's was helping her, look at work opportunities for post graduation. And she eventually found out that her now husband, who was in the military, was going to be stationed in Alaska. So fast forward to the spring of this year, just actually last month in May, she graduated our LIFT program with, the clinical team that we were also working with. She moved to Alaska. Her symptoms had been stable for an extended period. She had a plan to work in Alaska. She actually wanted to become a peer specialist. She's very happy in this relationship and she was ready for this new adventure in her life. And I think that, 3 or 4 years prior, any of that would have been a lot more challenging for her. But at this point, we're all very happy for her. She was ready, she achieved her goals. And I think that extra time with the step down services really kind of helped her get to this next phase in her life. Whereas back, in 2023, I think she wouldn't have been nearly as ready for some of these things. So that's my example.
Thanks so much, Hillary. Brittany, maybe we can try your audio now?
Hello, can you guys hear me?
Yes, we can.
Thumbs up, maybe?
We can hear you now. Thank you.
Oh, okay. Woo! All right, claps all around. I do apologize for that. Technology, guys. Okay, so sorry about that, but let me reintroduce myself. My name is Brittany Grimes. I'm a project manager here at the Oklahoma Department of Mental Health and Substance Abuse Services. I currently oversee our clinical high-risk psychosis grant. However, prior to overseeing that, I actually was the youth coordinator for our Healthy Transitions program, which is what I'm going to be talking to you all about today. And prior to that, when I was still in direct care, I actually worked under this initiative. So I'm very familiar with the work that's being done, and I'm very excited to share everything that our teams at both our sites have accomplished under this initiative. Next slide. Okay, so a little bit of demographic information about our Healthy Transitions Initiative. So currently we've served over 227 youth and young adults since 2021. Most of those youth and young adults actually reside in Oklahoma and Tulsa County. And of course, we contract with 2 certified community behavioral health clinics, one of which is Red Rock Behavioral Health Services in Oklahoma County. And their transition age youth team is called the Youth Empowerment Services team. And then we have Family and Children's Services of Tulsa in Tulsa County. Now, of course, this initiative generally serves the transition age youth populations between the ages of 16 and 25. However, what we've seen, the average age is between the ages of 18 and 20 years old, with 92% reporting a mental health diagnosis and 8% reporting a co-occurring disorder. And of course, there is no particular timeline of how long young people can actually stay in the program. But what we've also seen that youth and young adults typically stay in this program for about 7 months. Next slide. All right, so a little bit about our service model. I'm not going to go into full details about it. I'm just going to highlight a few things that I definitely think are important. So one of which is, of course, our first thing that a lot of our teams actually do is engage in community outreach. And so I think what I'll actually delve into a little bit more later is that the unique outreach opportunities that they have engaged with, because I think a lot of times when it comes to outreach or just getting young people enrolled in services, sometimes providers may rely on them just walking through the door or maybe connecting with them at an event that maybe their agency is at, or these 2 teams actually go to different entities and organizations that have contact with youth and young adults. What's also unique about our initiative is that, of course, when a young person actually is enrolled in services, they receive receive a care coordinator who is essentially a case manager and then a peer recovery support specialist. And so, of course, they have a peer support. They're walking with them through the process of going through services. And they're also helping that young person build advocacy skills and also understanding how to navigate through the child and adult servicing systems. And then, of course, throughout this whole process, we utilize the transition and independence process, which has been a great success for this work in regards to empowering the young people, in regards to achieving their goals and helping them towards greater independence and adulthood. Next slide. So generally, when it comes to actually bridging that gap for youth and young adults transitioning into adult services, what both Family and Children's and Red Rock does, they actually meet with the young person to discuss their treatment progress and the transfer of services and kind of what that looks like. And then from there, they actually assess if that young person is fully ready to transfer based off of transition planning that they do with the young person throughout their time in services. And then the youth and young adult staff meet with staff from their adult outpatient clinics to actually do case consultation. And usually those outpatient teams consist of like case managers, adult peer recovery support specialists, medication clinic staff therapists, and their adult outpatient clinical directors. And then, of course, in regards to case consultation, they also inform the adult staff about the services that they have on their end as the youth and young adult team, because they may have young adults that maybe the adult services team maybe feel they're not fully equipped to actually serve, or they probably need someone to really be give them really intensive services and intentional services. So they probably want to refer a young person from adult back to their youth and young adult services that are in their agencies. And of course, this ensures a warm handoff and a continuity of care when it comes to transitioning young people into adult services. And of course, when it comes to cross-system care coordination, both agencies actually focus on a holistic support, which is kind of falls under the umbrella of their contract as a CCBHC. So a lot of their work not only falls under helping with supports for mental illness, but also in general in regards to things related to school or their PCP, or maybe they are in need of disability services. And so a lot what our teams do, they actually go to these organizations, inform them about their services. And if a young person is in need of these particular services, they obtain releases of information to where they can actually coordinate care between both entities. And so of course, the emphasis is always placed on the whole person, wellness across the behavioral and physical health systems. Next slide. So this is kind of a list of a few of the cross-system collaboration entities that they both of our sites have actually engaged in. Of course, one big thing is, of course, the local school systems in both Tulsa and Oklahoma County. And what's wonderful about our CCBHC is they have additional programs that actually work directly in schools, which we call it the BIS program, but it's called the Behavioral Intervention Services and Supports in Schools. Try to say that 3 times fast. But it's a successful program where we actually embed a behavioral health coach within an actual school. And our youth and young adult teams actually partner with that behavioral health coach, who is also connecting with teachers and school staff in regards to finding supports and resources for that student in need. They also outreach to local universities and colleges and local inpatient facilities, because a lot of referrals for young people do come from our local inpatient facilities. Also, one of the great things that I think at least Red Rock has done was actually obtain an MOU with the Oklahoma Department of Rehabilitation Services, because I think this is a population that kind of gets overlooked when it comes to youth and young adults, those young adults that have disabilities. And what's so great about the Oklahoma Department of Rehabilitation Services, they have their own transition services. So pairing that with our transition services has been so impactful for young people in need. And lastly, of course, both our CCBHCs have access to first episode psychosis programs, one of which we use the Navigate model here in Oklahoma. And then, of course, the IPS model, which is the individual placement and support model for providers, which helps individuals with mental illness actually find and obtain employment. Next slide. These are a few of the partnerships that both sites have done. I want to highlight a few of them that have really amazed us here at the department. And I'm so thankful for the work that both of these sites have done. I want to give them the kudos if they're on this call. Thank you so much to you guys. Honestly, we couldn't do this work without you. So one of which for Red Rock, the wonderful thing that they told us that they've been able to obtain is a partnership with Brown's Driving School, to where if there's a young person that is currently receiving services with them, they actually get a discounted rate of actually going through their driving school, if as long as they stay in services with Red Rock. And the great thing about Tulsa Family and Children's, they've also have a similar program in regards to transportation needs for young people by actually having an MOU with Lyft in the county. So if a young person is needing transportation to and from appointments, Lyft actually provides a discount or no cost transportation for them. Also, what's wonderful that Family and Children's does, they also outreach to the Tulsa Dream Center, which is an organization that helps individuals that are experiencing poverty or homelessness. So they've done a wonderful job in actually making these connections with young people in need and that are impacted by these particular systems. Next slide. One thing we definitely want to highlight is our focus on elevating youth voice and choice, because I think one thing that a lot of us as providers and those across this nation always hear young people say is that no one ever listens to me. So we value that here at the department. And one way we try to elevate that with our grant initiative is really involving young people in what we do here. So young people are just not just recipients of care, but they're active partners in shaping it. And so taking this approach has made us more responsive, effective in offering youth-centered services for both child and behavioral health systems. These are a few things that we've done in regards to elevating youth voice and choice. Red Rock has done a wonderful job with partnering with 2 other CCBHCs in Oklahoma County to actually create the Community Group Social Spark Club, which is a great activity organization that they have where they invite young people from the community to actually have an opportunity to socialize and meet other young people just like them. We also have co-facilitated trainings here at the department with young people. That way young people have an opportunity to directly talk to providers about the services they're receiving, and also help providers know how to best support them as individuals as they're going through services. And lastly, of course, us here at ODMH are in the early stages of developing an informal advisory board, which we feel like is going to be really impactful in regards to the choices we're making as far as services that we're providing for youth and young adults. Of course, with these activities, young people feel more involved in the decisions that impact their well-being. It empowers them to advocate for services that are developmentally appropriate for them. It improves their engagement in services, and it helps to build a more stronger and more comprehensive system of care across their lifespan. And so what's next for us? So next slide, I'm sorry. So what's next for us? So of course, Red Rock and Family and Children's, they're planning on continuing this initiative, this particular work outside of the initiative, because I think this is the last year of our Oklahoma Healthy Transitions Initiative. But with the success we've had, they're looking forward to actually continuing this work within their agency. As far as ODMH and as a statewide initiative, we're actually in the process of creating a comprehensive work plan for all CCBHCs across Oklahoma aimed at providing service delivery for youth and young adults. So this plan will focus on increasing access to age-appropriate, developmentally responsive care by identifying and addressing service gaps, enhancing provider training, and embedding youth voice in service planning and delivery. So we're looking at creating other advisory boards in different areas of the state. We're looking at reimagining different outreach opportunities instead of just relying on young people to just walk through our doors. We need to go find them. So we're going to be working with CCBHCs on how their outreach is actually doing in regards to connecting with young people. We're looking at creating a transition support services and care coordination team within all CCBHCs to support youth transitioning from child to adult systems. We're looking at strengthening the partnerships and collaborations to youth serving organizations across the state, researching youth-specific performance measures, which we kind of already do, but we're really wanting to look at those specific measures related to this population and what's missing. What do we need to improve improve on, and how do we ensure there's accountability across the board with all of our CCBHCs serving this population. And then, of course, we're really going to be focusing on improving service engagements for special youth populations, such as those experiencing clinical high-risk psychosis, because, of course, we already have those programs that help individuals who are experiencing first episode psychosis. However, what we're finding is that they're not really focused on supporting a lot of youth and young adults. It's mainly adults. So we're going to be looking at how we can actually bridge that gap for them. And then, of course, we're going to be looking at how we actually serve our justice-involved youth and youth involved in child protective services. So, but that's about it for my presentation. Sorry if I talked real fast. I had to run through that, guys.
Thank you so much, Brittany. We so appreciate it. It's really great to hear about the program and all the work that you're doing. This has been so great. We don't have time for our Q&A session, but we have noted all of your questions in the chat. Just wanted to run through a couple of things really quickly just to wrap up. We will get back to you about the slides, and we will send those out to you through email. We do have a QR code here. If you want to provide any feedback on the webinar today, we would greatly appreciate that. The link is there as well as the QR code. And we do have a couple of additional resources. So when we send out these slides to you, you'll be able to see some resources as well as some links to references. So the next slide just shows some of our upcoming events. So the next slide shows some webinars that we have that are in July. So we have a couple of webinars, one on the clinical high risk for psychosis grantee program results on July 15th. You can register for that webinar. The link will be available to you. The role of peer specialists is also July 29th at 12 p.m. Eastern Time, and developmentally informed shared decision making will be August 12th. So we'll send out information so all of you can register for those webinars. And I want to say thank you all so much for joining us. We so appreciate your attendance and your participation. Have a great day. Bye-bye.